Yes, this works. Okay, I'm sorry, I can't do this in Danish. The Danish language sounds very familiar in vowels to me, because it kind of looks like a Dutch language, and of course I have seen all these Borgen television series, so Danish sounds very familiar to me, but I can't understand anything of it. And I will have to do this in English. I'm a professor of informal care in the Netherlands, and we've been working on aging and the social functioning of aging for a very long time now. And today I would like to bring the perspective to you of placing care, and informal care in particular, in the larger place of society. We have to, as a sociologist, I always think about how is informal care related to formal care, and what can we say about that from a more sociological point of view. So it's maybe not as practical as some of you in your hometowns or home organizations are working with care, but it may help you give the larger picture of how care is functioning in societies. And I would like to go into care networks in particular today. I think that's why I started out with placing care in the societal challenges that we are looking at today, and in particular the increased demand for informal care. I will talk a little bit also about how informal caregivers are getting into providing informal care, what drives them towards this, what are the mechanisms, and how the societal changes we are facing today are really impacting on these mechanisms of informal care. So there's a theoretical exercise, you could say. And then of course I want to go into more the issue of today, the formal and informal care networks, and how they are composed and how they are functioning, to what degree they are related to quality of care and quality of life, so the outcomes of care networks. And because Mature is very much into technological innovations, I will do a little sidestep into what we have done in a pilot project about digital communication in care networks, but that's not my core business. So, I would like to start out with this graph. This is from our longitudinal study, longitudinal aging study Amsterdam, that we are conducting since 1902 already. You can see here, let me see how this works. On this XS you can see the years, 1992 until 2012, which covers 20 years. And we have collected in this very long-term period, and are still going on with doing this, the information about how often people who are aged between 65 and 85 are using informal care or are using formal care. And formal care is here publicly provided informal care in the home, so help with household and help with personal care in particular. And then you can see, when you picture that on this very long time frame, that there has been a decline in the use of informal care, where here about 20% of this age group, 65 to 85, used informal care in 92. It's got down to about 9% of this age group that are using informal care, which is kind of contrary to what we are expecting of this group. But there are several reasons why this has been going down. But when you look at the use of formal care, you can see it's only 5% in this very 20 years ago, and it increased until about 7 to 8% in 2012. Also not a very large percentage in the Netherlands, it is, but it's still, you can see it going up. And I wanted to present this picture for several reasons. An important one is that in this era, in 92, 20 years ago, the system of formal care was kind of working around substitution models, as you could say. Whenever there was informal caregivers, you didn't get the chance to receive formal care at home. And you can see this substitution large divide in '92 to be very prominent in this figure. When you look at 2011, you can see that they are getting more closer, and we also did the analysis to get the empirical evidence for it, and you can really see that over this time we are changing from a system of substitution to a system of complementarity. So whenever older people are using care, they're more likely to use a mix of both informal and formal caregivers. But of course, there are so many societal mechanisms that are behind this large picture. Because society not only changed in these 20 years, but also, of course, the older people. We are talking about people between 65 and 85, so we also know that in this age group, the health problems went down for a little bit. They were more higher educated, better living conditions, and those kind of things. So behind the explanation of these changes are not only to be solved in individual differences, but also in societal differences where the changes, the policy system of long-term care has also evolved in a very long and important way. This is the picture that our study provided over the past 20 years, but it's far more important to look ahead, to look what will be happening in the next another 20 years, for instance. And then we have to realize that there are several major challenges in our society that are really working out on how this use of care by older people will be transformed in the next 20 years or so. Of course, we know, everybody here knows that we're dealing with an aging society, that we are really confronted with a larger proportion, larger absolute numbers of older people, and particularly the 85 plus will be increasing in absolute numbers in the next 20 years. That will be happening in the Netherlands, but especially will surely also happen in Denmark. So we're facing with a lot of 80 plus people with long-term care problems, complex care problems, we know that. We're facing in the Netherlands, but I guess that's the same here in Denmark also, with a large change in the reform of long-term care. Major issue in the Netherlands is that they're really cutting down on residential care, that you're only allowed to enter residential care when you're really dependent on health. You need help for about 24 hours per day. And that leaves a large group who is also in need of help living in their own homes until a long time. We also have a very normative discourse about who is more responsible for taking care of these dependent people, and that is changing. The government would like that to change more towards the family and the social network of older people, so that they take up more responsibilities than they used to do before in the past 20 years. We're also looking at an increased retirement age, so it has been raised from 65 to 67 recently, and it may increase even more. So informal caregivers of older people are likely to be between 60 and 80 years themselves, or 80 and 60 and 70 themselves, are likely to combine work and care, which makes it, of course, not very easy task to do. And another societal change that has been more on the long term is that we're also dealing with different types of families, more complex types of families, like families that were of people who divorced earlier in life and remarried, for instance, and we still don't know very much about how step families are taking care of their older parents, for instance. But there are also far more people living alone, having smaller families, and there is a large mix of also homosexual older people who are also not very keen in receiving care from family members. So there might be a changing shift in the traditional family force, and which might affect the decline in family solidarity. We're still not very we don't know very much about that yet. What we do know is that in the next 20 years or so, we have a lot of challenges for the old and their social networks in order to prevent this social frailty, loneliness, and this lack of informal care. I think that is one of the major tasks for the next 20 years or so to come. Okay. So I want to take you a little bit more into the informal caregiver, because that is one of the important caregivers for the next era. So when we ask in our National Institute of Social Science has national surveys about to identify informal caregivers every other 2 years, and they ask this question. To identify an informal caregiver. Did you provide help to someone you know, so someone in your network, who suffers from health problems in the past 12 months? And they give examples of parents and children and so on. And also the types of help that you may be doing. So if you look at this screening question, I was wondering how many of you in this audience would answer this by saying, yes, I'm an informal caregiver as well. Oh, still many, I guess. Not, but 15 or so from this audience. And how large would you say that the proportion of informal caregivers is in the population of Denmark? Do you know how many caregivers you have in the population, general population? How large is the percentage? How large would you expect that to be? How many of your older adult population is an informal caregiver? 20%? More? Less? More? More. Okay, in the Netherlands it is 33. I'm not sure, I don't even know how much it is in Denmark. It would be nice to know, to look that up. But when you use this screening question, 33% of the population over 18 years is identified as an informal caregiver, and in the Netherlands that adds up to 4 million of this old age population. So there are a lot of informal caregivers. There are many people out there doing anything, providing support for informal caregivers. When you add the criterion to it that you have to provide long-term care, so over 3 months, and also intensively for 8 hours per week or more, I think that from a policy view, that is the most important group of informal caregivers to identify, because these are risking to be overburdened in this long-term environment. And then you cut down to only 4.7% of this of the group of the population of 18 years and older. So that is a larger amount, but I think it is the most important group. Well, we also know who are informal caregivers. Most of these, when you do this population survey, are children caring for their parents or parents-in-law. About 45% of all informal caregivers are adult children providing care to parents. They provide it less intensively, often combined with work, and they also often share it with other informal caregivers or with formal caregivers. We also know that only a smaller percentage of the population over 18 is providing care to its spouse, but that is a larger proportion when you look at the 55 plus population, for instance. But we also know that spousal caregivers are providing very intensive care, very long hours, very long terms. And they also use that with little help from others. There are also other people providing care to others, but in a lower proportion. So friends, non-kin are occasionally providing help, and usually as assistants to spouses and adult children. We know this is a very general picture of who informal caregivers are. But you see also that there is a difference between hours of providing informal care. It has to do with the relationship, it has to do with the possibilities or the opportunities to provide informal care. And when we look at, we can define this in a more theoretical way and define a model that we described in our European Journal of Aging paper in 2016. We identified 4 important mechanisms of providing informal care. And what drives informal caregivers? If you want to increase the number of informal caregivers, you have to know what drives them, right? So, and the first mechanism of importance here is, of course, what type of care is needed? What kind of help does this older person need? That is one of the most important drivers of informal care. There is a need for care. So your mother really broke her hip, has been in hospital and now comes home and needs occasionally help with a lot of personal care and household care, for instance. But you can also look at persons who are suffering from dementia or slowly growing, increasing their problems and need help for a very long time. So that's one of the major drivers. So it's a very thick mechanism here which helps identifying who would provide informal care and why. But the second one is, of course, has to do with individual preferences, individual attitudes. When my mother needs help, do I feel far more responsible to provide informal care? And you know, that can differ between children, even within one family. But it can also differ between spouses, between children, between non-kin neighbors, for instance. So we have to consider quality of relationships, norms, attitudes, also as an important driver of informal caregiving. It is a very important one. So what is needed? What do I want? But there's also a very important third one, and that is what can I do? I mean, to a large degree, we can be restricted in time because we work full time or we live at large distances from our parents, for instance. We may have our own health problems in case of older spouses. So restrictions are also very important to look at. And they are less important in an empirical sense. They show to be less important than the first two. Finally, the fourth mechanism is to be identified is who is also providing care to this person in need. Who are the others that are providing care? And here comes in the professional caregiver, the formal caregiver. We know that here's this substitution complementarity mechanism at stake. So when there is a professional formal health care, home care available, informal caregivers do not need to do as much, and then you have a negative relationship here. But you can also say that the more professional help there is, the more informal caregivers can help because they want to share the care together. These are the four mechanisms that we identified based on empirical evidence in a theoretical sense. And when you can use these four mechanisms to understand why, for instance, spouses do more care than children, but also how the provision of informal care may change over time or may differ between countries even. But the change over time is the most important thing here, because when we look at the new era we are in for the next 20 years or so, we know that we have to deal with this new policy context to reform the restrictions on professional home care, for instance, and residential care, and the increased need for care in our aging populations. So that places a large pressure on this one, on this first mechanisms. We need, there's a large increase in the need for cares, and that was one of the most important drivers for informal caregiving. But there is also this discourse of the changing responsibilities, the shifting responsibilities towards families, towards social networks, that we have to take care of each other again in our communities. So the expectations towards social network members, towards community members are increasing. given the restrictions, you could say that we have encountered more restrictions in terms of time, for instance, that because we have to work so much longer, also combine our informal caregiving tasks with employment until later age. But that was so that should be more restrictive in providing informal care, but we showed it before that it is a mechanism of lesser importance. We also know that due to the reforms, we have less formal help available. There's less home care. We have important budget cuts on household care, for instance, in the Netherlands. And household care is something that is easily replaced by social network members as children and neighbors. But then they still need to do this and want to do this and be able to do it. When you look at the changes, you can reason or argument here that, it is very likely that in the next era or so, we can still rely on a lot of spouses and a lot of elder children to provide informal care to their parents or to their older spouses. But we can also reason that this will not be enough because the need for care has extended so much. People with Alzheimer are living 10 to 15 years right now. So the time that people need care at home with longer care, with important complex care problems is really increasing. So we need more. We need more to be happening here than just older spouses and adult children providing even more care, because that's not what they are able to do for a very long time. So we need to, one solution would be to extend the caregiver network in order to provide informal care. So we have to look beyond spouses and direct core relationships and look at other kin that may be of assistance. We look at the social network, at neighbors, at friends, and maybe also at volunteers, because that is also an important part of informal caregiving in society. So this whole theoretical argument, you could say, stresses the fact that we need larger care networks, we need more informal caregivers, more different types of caregivers, and we need to have informal caregivers work together with formal caregivers. And that's how I come to my study on care networks. So is this actually happening, and is this, to what degree is this already occurring in the lives of older people? That brings me to the empirical evidence that we have about care networks in our longitudinal aging study. So we have this triangle of older persons in need of care, and I'm now shifting from the caregivers to the care users in our study. We identified persons that are using informal care as well as formal or formal care. And we know that when we look at care networks, we have there are very different mechanisms in how these two types of care network, partial care networks are functioning. Social network members argue according to these mechanisms that I just described to you. They have their own individual driving mechanisms to provide care. But the formal caregiving is of course bounded by home care organization policies, practices, in particular how they formulate their options and possibilities to support informal caregivers, to deal with informal caregivers, to engage with them, to communicate with them. So this is an important new element of study in the study of in care networks. We identified care networks as all people, informal and formal, who provide care with different types of tasks: household chores, personal care, nursing, guidance, and also arranging care. And when you do that, we see that they can differ in size and composition, and particularly in the share of informal caregivers. Not everybody has the same type of composition of care networks, and they also differ in the connection between the two partial networks. We can put that in picture here. We asked 607 older adults in our LASA study at a specific wave who helped them out with either at least one of those chores. Put that in a cluster analysis type of analysis, and then we identified 4 typologies of care networks. That all differ with regard to the share of informal caregivers present in this network, but also the types of informal caregivers. We identified a formal network which had a relatively large number of publicly provided formal helpers. So this is a network that is mostly there are mostly professional caregivers providing help in the home, and there's only a limited number of informal caregivers here. This is the second type, the informal network, that identified a large number of different types of informal caregivers, so children as well as other kin, family members, non-kin, privately paid household help, for instance, and also a little bit of formal caregivers. So this is the care network that maybe national policymakers would like to exist and to develop over time. Because it has a large share of informal caregivers. Here we have the spousal network. Whenever there is a spouse still present, which is not the case in this type of network, you see that he or she is most likely to provide care on his own, and that only very few other informal caregivers are present and very few other helpers, especially formal caregivers. And when we identified it in these type of networks, also identified a privately paid care network, which is mainly to be understood as the household help that is privately paid, for instance. And this is more often found with people who are with very little health problems still. The most interesting types are the 3 above here. And as said, so it's very important to acknowledge that the share of informal caregivers and the types of caregivers are very varying for a lot of older people. And the question is, who is developing which type of network? In this paper, we wrote all about this, the Journal of Gerontology, Social Sciences. Health problems of the care recipient are, of course, the major determinant, driving determinant of this, who is providing care, and especially also the presence of the spouse or not. I mean, those are the 2 major drivers. But we were also very interested in to what degree the social network that was already present, that the social network of this care recipient also translated into caregivers and into the type of caregivers. So we looked far more at, okay, do these care recipients have care network members living within proximity, within 50-minute distance, so within their social neighborhood, you can say. And does that matter to what degree the type of network, to which type of care network is developed? And it's clearly visible here that whenever children are living within proximity, they're far more likely to to develop an informal caregiver network, and they're less likely to be included in this formal mixed type of network. We can see that all these numbers are larger than in this area. So the development of a formal care network is also in part due to the fact there are no people living within, or less people of the social network living within proximity. This is also an important issue. We can see that the spouses who are less likely to use these informal care network members do actually have people living within their neighborhood. So they do have friends and they do have other non-kin neighbors, for instance, also here. But these people are not included in their care network. So you might say, conclude that this is an underuse of the potential caregivers in the social network by spousal caregivers. So proximity is important. We have to look for within the social network of all the people who are able to potentially provide care as well. And we know that local relatives and non-kin are underused, especially by spouses, so we may need to help these spouses get along to mobilize these types of caregivers. To sum up for this part, health needs of the older focal person are the most important drivers for what type of care network is developed, living arrangements as well, with or without a spouse, but the proximity of social network members is also important. The paper we wrote also showed that the preferences and attitudes of the older care recipients also were important. Didn't go into that right now. And of course, when you have to when you would replicate such a study, for instance, in Denmark, you would have to take into account to what degree the availability of professional, publicly paid home care is available, because that's also a very large driver of how personal care networks are developed. Whenever that is easy accessible, easy to get for a lot of people in care need, that would be much, the share of professional home care givers would be larger. I have how many minutes?
15 including.
Still 15?
Yeah, including questions.
Including questions, okay. Okay. I want to show you a little bit also about, now we talked more about how care networks developed, but what is most interesting also is, does it matter what type of care network you develop around your older person, to what degree that adds to his or her quality of life. And I think we've done too little research on how care use is related to well-being, for instance. And we decided to look into this with more specifics than has been done before. So we know that poor health, a small social network, having little resources in terms of money and those kind of things, are really related to poor quality of life. We know that. We know that poor health suffers, people in poor health suffer from depressive symptoms, are more lonely as well. But we just argued that these resources also define to what degree, what type of care network is developed, to who the caregivers are that you have around you. And this care network may provide more or less better or poor quality of care, which may add to this quality of life. And we have never really looked into that before, to what degree we can empirically assess to what degree care networks and the quality of care within that network really adds to quality of life. So this was the main objective of this new paper we're writing. To what degree are structural functional features of the care network associated with perceived quality of care? We also have measures for that. And to what degree do we understand that poor health and quality of life are related, but part of this association is explained by the characteristics of the care use network and the perceived quality of care. Just for the results, quality of care was identified in our study by to what degree are you still able to control care, perceived control over care? Do you feel that you're still able to deal with who is providing care, at what time are they providing care, what type of care you receive, so the control over care. That was an important measurement in our study in this respect. And are you satisfied with the care in general? And the results of this study showed that the more caregivers are present, the less control over care people have. And we can, of course, understand that. Because whenever there are 23 people around you coming in to do all these different types of chores in your household, you can feel really overwhelmed by this and lose control over care. So the size, but also the composition of caregivers is really declining the control over care. And it's not only the use of formal care here, it's also the help by informal caregivers that gives all the care recipients a feeling of that they are losing control over care. So we also have these negative associations here when they receive help from children or help from other relatives. So there's something, receiving help makes you feel more feeling dependent upon others and losing control, which is not a very good thing. Professional home care, the use of professional home care even had a more stronger effect on perceiving losing control over care and being dissatisfied with care in general, which is also a really important message, I guess. So whenever older people living at home with complex large care network, many professionals but also many informal caregivers, they are kind of losing control over life and are less satisfied with care. Now, does that in fact impact also on quality of life? That is shown in this table. We can see that health is very important in, for instance, the depressive effect that people are reporting. But in addition to health, we can see that the being satisfied with care also has a negative effect on feeling depressed. We also see that the use of professional home care is the most strongest determinant of feeling more depressed in later life. Really not a very good message here. So we can conclude that care networks, in particular also quality of care, really adds to quality of life. In addition to health problems, social networks, and other determinants of quality of life. So I think this message is very important because in particular the professional home care contributes to less quality of life compared to informal care. Help from a spouse, for instance, is not related to a large degree, or help from children is not related to a large degree to depressive symptoms. So this really brings, helps bring them, I wanted to help bring this message across that once we are in the homes of these older people as professional caregivers, we're doing something that is not really right. And maybe we could do more than just provide care in nursing terms or in personal care, because there's more needed to adjust to living with severe health problems, for instance, or feeling dependent because of and losing control and those kind of things. This is, I think, for both informal caregivers as professional home caregivers, an important message. And to close up, because this is mature, dealing with technological innovations, one of the solutions that having professional helpers as well as informal caregivers in the home, in the care network, and improve the quality of care they deliver is maybe the communication between the two. Professional home caregivers, nurses, or at a lower level, household helpers, are not likely to communicate with informal caregivers in a very easy manner. They're not very used to do that. They don't even have the time to do it, probably. So maybe digital communication tools helped. Of course, the first point is also important. Informal caregivers are not always living in the household, so it takes an additional effort for professional caregivers to encounter these informal caregivers, like these adult children or neighbors or whoever. So digital tools may bridge this kind of limitations as well, because it can bridge distances. So we know in the Netherlands there is a large variety of digital communication devices, and we try to study the use of this digital tool in a very small pilot, 7 mixed care networks. And it's a device that, or it's a piece of software that you can, it's like a WhatsApp group, but then you can use it in a closed digital network, for instance. Internet use, you can use it by smartphone, tablet, personal computers as well. And it contains a diary, contains the tools for messaging, for communication, into specific groups and to specific users. So the care recipient may be one of the persons, but also the informal caregivers and the professional home caregivers were part of this network. And we decided to, well, the home care organization we worked with helped us to provide with money to do a 6-month follow-up of the communication within this device. So we used login data, we studied that from who's talking to whom and what are they saying and what are the responses and those kind of things. We tried to evaluate to what degree this impacted also on the offline communication, like the calling or sending messages by email, those kind of things, or talking to them in person. And these 7 networks showed that these devices are used for different types of communication, you could say, and that was also very important, related to the characteristics of the care recipient, as well as who was present as an informal caregiver. So in about 2 of those networks, they used the device only to stay in touch.